Welcome to the latest edition of the TIRADS MDS. As usual, we have some excellent cases and a wonderful panel discussion. Just a reminder that you can find these online and on YouTube. And the newest TIRA offering is The Voices of Wisdom, which is a podcast. There are 3 or 4 of those out there and really are designed to deal with things we're dealing with every day, practical management of thyroid cancer, and some wonderful resources for you to listen to. And there'll be a new one of those that comes out each month. So our panel this morning is an excellent panel from all over to discuss the cases. And I'll go around just the list here and have folks introduce themselves. Dr. Hartl.
Oh, hi, everybody. Dana Hartl. I'm a surgeon at Gustave Roussy Institute in France. And I apologize for those who tuned in last week. You have to see me 2 weeks in a row.
We refer to that as the bonus, which is awesome. Bruce.
Yeah, hi, Bruce Culliney. I'm a medical oncologist. As Margie likes to say, I work with Margaret Brandwein and at Mount Sinai.
That's awesome. Dr. Robenshtok.
Hi, I'm Eyal Robenshtok. I'm an endocrinologist from Israel.
Fantastic. Dr. Langer.
Hi, everyone. I'm Jill Langer, a radiologist at Penn, and I co-direct the Thyroid Nodule Clinic at Penn with Susan Mandel.
Thanks, Jill. And Dr. Brandwein.
Hi, I'm Margaret Brandwein-Weber. I'm a pathologist. I'm chief of pathology at Mount Sinai West. I'm a director of a head and neck pathology fellowship, and I work with Mark Ergen.
You poor thing. Fantastic. And our presenting person this morning is Dr. Roth. Dr. Roth, can you introduce yourself, multitask, and bring your slides up all at the same time?
Yes, good morning. Thanks for having me. Oh, now I'm to someone else. Here we go. I'm an endocrinologist at the Fred Hutch Cancer Center in the University of Washington, where I'm the director of our endocrine tumor program.
Fantastic.
So let's make sure these slides are visible to everyone.
You are good to go. Let's do the
Perfect.
first case.
Yeah. So the first case is a 32-year-old woman who presented with a palpable thyroid nodule. She had a history of aplastic anemia several years prior with an allogenic bone marrow transplant in 2016, including whole body radiation. And the treatment was complicated by GVHD, aspergillus pneumonia, and drug-induced hepatitis from amphotericin, all of which resolved by 2017. So she presented with a new left palpable neck mass after a viral infection in January of 2022. She had also been undergoing infertility treatment and had been undergoing ovarian stimulation for egg retrieval to undergo IVF, but had had 2 inadequate stimulations thus far. The labs ordered by her OBGYN showed normal thyroid function, and her exam was notable for a small palpable right upper thyroid nodule that was smooth and mobile with no palpable adenopathy.
Hold there just a second, Mara. Eyal, think out loud for me. This is the Thyroid Cancer Tumor Board. This is going to be thyroid cancer. When you look through this history, what are the things that you're sort of thinking about?
Okay, so 3 things. One, it's a palpable mass. It's going to be larger than the incidental tiny thyroid cancer. And most notably is the history. So when we take the history, we want to see if there's anything that's going to interfere with the treatment we want to give, and specifically with radioiodine. So she has allogenic bone marrow transplantation. I wouldn't be thrilled giving her radioiodine, which may decrease blood counts. And she has infertility and has treatments. Another reason that I wouldn't be thrilled to give radioiodine. So in this case, she's gonna need a really good indication for us to give to treat with radioiodine.
Yeah. So Dana, think through a little bit with me that as well. So this is a person that we could give radioactive iodine if we needed to, but we're really probably not going to be leaning that way. Does that change how you think about total versus lobectomy, more or less? Without knowing the specifics of the case, how do you think about that?
Well, it is palpable, but then it still might be low risk at the end. So I wouldn't be, I mean, we're going to look at the ultrasound and we're going to need an FNA, of course. But if this, even if we're palpable, I wouldn't bother me to do a lobectomy on this patient and then really get the specifics on the lesion. And then if it's really an intermediate or high risk case, then discuss the total thyroidectomy and to be able to give radioactive iodine. So now that I was kind of a staged surgery would not shock me.
Fantastic. Okay, Maura, where do we go?
So she, this was her initial ultrasound that she was sent for.
Jill, help me out here.
I don't think you need help, but happy to talk about this. Yeah, so here we have a nodule that really has all the prototypical features of a papillary thyroid carcinoma. It's taller than wide, it's hypoechoic, it has infiltrating margins, it has a variety of echogenic foci, but you know what? You don't have to sweat that detail because you're already at the highest level. My attention would turn to looking for extrathyroidal extension, cervical lymphadenopathy, which seals the deal. Always checking the other side for suspicious lesions now that we have this conversation about hemithyroidectomy versus total thyroidectomy.
Beautiful. Okay, Mara.
So this is actually a video of that ultrasound, just to give a little bit more detail. But overall, at the time, it was described as a diffusely hyperemic gland suggestive of thyroiditis, and this was right after her viral infection with this solitary 1.8 centimeter thyroid nodule that was TIRADS V. So she declined a fine needle aspiration at the time. This patient has a lot of PTSD, I think, from her prior cancer treatment, and so she asked if she could just have repeat surveillance and not get an FNA right away. She then underwent 2 more rounds of intrauterine insemination, which were both unsuccessful. And then instead of returning for her neck ultrasound, she left for 6 months and went to Europe for a sabbatical. So at that point, she then returned and finally came in for her repeat neck ultrasound.
And you want to take us through that one, Mara, since it's a video there?
Sorry, what was that?
You want to take us through that one since it's a video? It's hard for Jill.
Are you
Yeah,
able to see it
either
at this
way,
point?
yeah.
You can do, Jill? I mean, this is like flying on the fly.
It's
Go ahead,
okay.
Jill.
No, I can see it very well. Thank you. Yeah, and on this video, we can clearly see that there is macroscopic disease to the right lateral neck. I don't know if Margaret can pedal back through this or not, but you can see that in one of the nodes, looks like a level 2 or 3 node in its inferior aspect. There is a hyperechoic tissue deposit in that node, and I would imagine if you put color Doppler on, it would light up like a light bulb. And just going back to the importance of assessing lateral cervical lymph nodes, even at the beginning, I think there were some very subtle features. Certainly when you see a suspicious lesion, and really in any patient, you should do a very detailed look at the lateral neck. If the original differential was focal thyroiditis versus a tumor, as soon as you see lateral compartment lymphadenopathy, any sort of subacute thyroiditis or other changes would really go away. You'd have to be concerned about malignancy.
So at this point, she did go ahead with the fine needle aspiration.
And Margie, can you help me here? I know you do the usual disclaimer. I'm not a cytologist, but you're closer than I am. So
Yeah, so, let me start by saying this poor woman has been through the medical ringer. So, given the delay in any kind of attention to this tumor, of course, we're all concerned about, grade progression. Looking just at this, you see in this very center ball, right? And the thing is about touch prep or FNA, PTC nuclei come out nicer there. So what you can see is kind of like a ball of irregular cells. The nuclear contours are irregular. So, as a non-cytologist, it would be very easy for me to say, oh, this is diagnostic for PTC. Oh, and what do they say? Undetermined fluid. There you go. That's why I don't do this for a living.
better than me. It looked like a blob to me. So
Yeah.
So it's Washington State, so we have to have molecular testing. So what?
Well, so she did have an indeterminate result. So she did get ThyroSeq testing sent, and it showed this positive ROS1 fusion that they described as having a high probability for cancer.
Perfect. Anybody know anything about ROS1 fusions? Somebody can ring in on that for me.
Really rare.
Yeah, me neither. Thank goodness I get to see the slides before. So unusual fusion
I'm sorry.
for thyroid cancer. Go ahead, Dana.
No, I just wanted to ask a question about that lymph node. She didn't want the cytology on the lymph node because that would have really helped too, even if the tumor itself is indeterminate. If you had thyroid cells and thyroglobulin, a really high thyroglobulin in that despite her having her thyroid in place, if you had a really high thyroglobulin level in that node, that would be diagnostic, wouldn't it?
Yeah, she actually refused to have the FNA of the lymph node that was on the second exam, was actually then palpable. And so she declined that as well. She said, let me focus on just the thyroid nodule first, and then I can think about the rest later.
So you're firmly somewhere between shared decision-making and negotiation? Is that
Yes.
where we are here?
Very much so.
Yeah, and as Margie said, she'd been through a lot in the past, right? So
Mhm.
so yeah, so absolutely. So then she moved ahead, all right, and here's your preoperative consultation. Go ahead, Mara.
Yeah, so she was really very concerned about undergoing any surgery and was requesting active surveillance for this, despite our very strong recommendation to have surgery. At this point, she now had palpable adenopathy on that right lateral side, and we wanted to do an FNA of the right lateral node that you could see on the ultrasound, but she declined that as well. And so she did eventually consent to have a hemithyroidectomy and said, if it's really cancer, then I'll do the rest of the surgery.
So Eyal and Dana, take me through how you sort of think about this. Obviously, our standard approach, she's got N1B disease, it would be surgery. She's not wanting that. How do you start first, Dana? How do you have that discussion with people?
Well, I think the problem here also is that we really, I mean, we know it's cancer, but she doesn't have the proof yet. And so I think she needs to, I mean, there's still a doubt, and she still has this hope that it isn't, or that it's something that's low grade or whatever. So yeah, she needs to do what she needs to do given her history, I think. And so we really need to be very, listen to her and be very kind. And for now, I mean, I saw the other slides, but for now, we don't have, it seems just like it's papillary. It's got a, it's maybe growing a little bit fast for a regular papillary, but for now we do have time to do the rest, and we can do it step by step. So I don't think her survival is any danger if we do it step by step and let her gradually accept the fact.
Yeah, and Eyal, you've probably faced this situation because you're now being known for watching with active surveillance and minimalistic management. People that come to you wanting minimalistic management, that in your heart of hearts you don't think that's the right thing to do. How do you have that discussion with people?
So many times I tell them, well, the best chance you had for active surveillance is with me, but it's really not suitable for active surveillance. So you can be sure that it's really not suitable for active surveillance. Now, in this case, it's a long discussion. I'm sure Mara did everything she could with the discussion and explaining everything. One point, sometimes we have a suspicious lateral lymph node, and we can't do an FNA for one reason or another. It can be coagulation problems. It can be just it's too deep behind the vessels. So we have several options. If it's a widespread disease in the neck, we can do a PET CT. We can, during surgery, we can have frozen section. And if we have one malignant lymph node, we can do the whole dissection. So we have some tools, but the problem was the consent. So we're limited by that. But at the end, it's the patient's body and it's her decision.
Got it. And Mara, in her case, was it her sort of not being convinced it's thyroid cancer in the thyroid, or she just wanted the big lump out of there? Did you get a feel for that?
Yeah, I mean, we talked to her about how this was really consistent and convincing for thyroid cancer, that the adenopathy was clearly very concerning for cancer. And she just, I think from her underlying anxiety, really wanted to know for certain and have the most minimalistic approach, even though we said this, you're likely to have to go back and then have more surgery. But she really just wanted the very bare minimum possible to be sure it was clearly surgery before moving on for more treatment.
Yeah.
Just one more point. The growth of the lymph nodes was pretty quick. Within between 6 and 12 months, she had like a lateral neck filled with metastatic lymph nodes. It's pretty unusual. We don't see it, the progression this fast usually.
Dana?
Just says it's an upper pole lesion, though. So upper pole lesions, when they metastasize, sometimes they go just directly to the lateral neck also. So that maybe would explain why we're seeing it in the level 3 or level 4 instead of in the central neck.
Right.
The other thing that just came to mind is still thinking about that ROS1 fusion that we had. That is a targetable mutation. In I think non-small cell lung cancers, it's targetable. And am I right, Bruce? I think FDA approved for some of those. So
Yeah, it is. I know for like crizotinib, and but it's still very uncommon in lung cancer as well that I know of. But there's actually a good response rate in the very few patients that have the mutation.
right, I think it's 1 or 2% even in the lung cancer
Yeah,
patients.
that's
Rare it is. But even as we're sort of thinking about this, if this was going to be aggressive, just knowing that ROS1 was there does give us a potential mutation to target. Not necessarily right now, but thinking about those lymph nodes that were growing so fast made me sort of think about that. All right, Mara, so where do we go? What was surgery?
So she went on to have a hemithyroidectomy because that was what she was willing to start with. And so this is her pathology.
Margie?
Right, sure. So here I am in my wheelhouse. It's from here, it's looks rather diffuse because you see the whole gland has these big knots of cancer in it. So one possibility, although you just can't make it from the slide, is that this is a diffuse invasive variant. Those could be diffuse with a papillary architecture, with a classic architecture. And I'm able to see that this has a papillary architecture, or the other option, which I don't see what's going on here, could be diffuse follicular variant. And another question here is, okay. Sure. I was going to say, when I looked at the slides originally, I was wondering if there was a solid component which is associated with the red PTC, which is now renamed rearrangement, but that's not what's going on. And here is, PTC. It's read the book.
So yeah, this was a 1.9 centimeter classic variant papillary thyroid cancer. There was some focal angioinvasion, no lymphatic or perineural invasion, no extrathyroidal extension, but she did have a posterior surgical margin that was positive.
Yeah. So, that's something that kind of bothers me when ETE is not a easy and uniform feature. And now, because of the change in staging, it's also not quote unquote an important feature. But when people report a positive margin with no ETE, and of course all this adenopathy, it's hard for me to believe there really is no ETE.
All right, Mark.
So at her post-operative visit, she agreed to undergo the FNA for the lateral nodes. And so both a right level 5 node and left level 4 node were positive for papillary thyroid cancer. But prior to the cytology results coming back, she actually had a positive home pregnancy test. And if you recall, she'd been undergoing infertility treatment for about over a year at this point, with several rounds of IVF and IUI.
All right, Dr. Robenshtok, you talked her into the surgery that she wanted, and then she pulled the trump card on you. She's pregnant. What are we going to say here?
Mazel tov.
So,
You're going to say mazel tov.
Yeah, so. So in this case, it's one of the unusual cases. I would like to see her thyroglobulin, just to see if it's 30, 40 or 300, 400. Do we have this metastasis? Is it only the neck? Usually, if it's only the neck, we don't see anything else, then we usually either do surgery during the second trimester or after delivery. In this case, I would tend toward second trimester because it's a fast-growing tumor, but it's going to be a discussion with the whole team, including the surgeons.
So Dana, I always tell these folks that we could operate during second trimester, and then I try to find every reason not to, even though OB/GYN doctors tell me it's perfectly safe. How do you sort of think about this?
I totally agree. I think, she really wanted this pregnancy. She's had a hard time getting pregnant. I wouldn't want to do anything that could endanger that pregnancy. So even if they said, yeah, it's okay, no risk, there's never no risk. So yeah, I do tend to try to convince patients to wait until at least after delivery.
Yeah,
definitely.
If I'm honest, that's even in the setting of lateral neck lymphadenopathy.
Yeah,
Right.
really.
I get a little more worried if it's central neck, but even then.
Yeah, even if they grow, what'll they grow? Maybe a couple of millimeters. It's not going to change the surgery. Maybe we'll have to do a few more neck levels when we go back in. But we have no evidence that shows that it's going to change her prognosis in the end. So.
I find most of the ladies are comfortable watching until they can feel them. When they can start to feel them at the second trimester, sometimes that makes them a little more nervous. So Mara, what did you guys decide to do here?
So we were planning to continue surveillance, but she was actually particularly anxious about being pregnant and having active cancer. So suddenly now the role has switched here. And so our plan was to do surgery postpartum unless there was clear evidence of progression. And so the patient wanted to be very clear about what did progression look like, how would we know this was progression, and what would be an indication for surgery. She actually at some point was considering whether she needed to abort the pregnancy because of her cancer diagnosis. And so thankfully we were able to reassure her that it was okay to proceed with the pregnancy. And her maternal fetal medicine specialist agreed that it was okay to continue the pregnancy and to just reevaluate at the second trimester.
Perfect. And yep. Okay, keep going.
So we did a repeat ultrasound at around 18 weeks gestation, and she had no recurrence in the thyroid bed, but the adenopathy, both on the right and left side, had increased quite dramatically in size and in the number of abnormal nodes. So at that point, the discussion was made whether or not to continue with surveillance versus to undergo surgery. And we chose to proceed with surgery actually in the second trimester, and her maternal fetal medicine specialist agreed.
So Dana, since it's just the six of us sitting around chatting and nobody's really listening to us, the standard party line is you'll do exactly the same surgery if she's pregnant as she wasn't pregnant. Although I can't help but think what a disaster this would be if she got hypoparathyroidism during pregnancy.
Yeah.
So are you really, really going to do the same surgery now that you do postpartum?
Well, I'm going to, yeah, I would try to do as much as possible. I'm not sure if I would want to know what's going on in the central neck. I'm not sure I would go back into that central neck that had already had the surgery. And that's maybe one thing that was good in this case is that there is some retrospective evidence that shows that stage surgery, there's a little bit less risk of hypoparathyroidism postoperatively. So I would be a little bit less worried about that in this patient. So yeah, going back in on the other side, I don't think so, but we would definitely try to clear out as much as possible. I mean, as much as I would do as much as I would normally do.
Gotcha. I'm with you. All right, Maura, how did this work out?
So she underwent a completion thyroidectomy at 20 weeks with a bilateral central and bilateral lateral neck dissection. And even though on ultrasound, her lymph nodes were, multiple lymph nodes, 2 to 3 centimeters in size, on pathology, actually, she had less adenopathy than we expected, with only 7 out of 26 positive nodes on the right, up to 9 millimeters in size with extranodal extension, and only 1 positive node on the left side that was up to 9 millimeters as well with extranodal extension. She then delivered a healthy baby girl, but her initial labs postpartum showed that her TSH was nice and suppressed. She had no parathyroid dysfunction, and her thyroglobulin was elevated at 19.2.
All right, Dr. Robenshtok, there's the thyroglobulin you were asking for. What are you going to do with that?
So this is already after total thyroidectomy and neck dissection. So this is a high thyroglobulin. At this stage, we would do obviously a neck ultrasound and a PET-CT because we want to see the whole body. We want to see especially the lungs. Usually, if we have metastasis in the bones, in the skeletal muscle, then the number is even higher. So I would worry about distant metastasis or significant residual disease in the neck. Sometimes it's retrosternal and we don't see it on ultrasound. I'd like to see where it's coming from.
Got it. Dana, what are you thinking here?
Yeah, definitely. I'm thinking it's either a missed lymph node, because sometimes when they have 7 lymph nodes is starting to get a little bit high, and sometimes they miss them, particularly if, like Eyal said, they're down really low, or retropharyngeal. So yeah, imaging would probably be a really good idea here. Maybe nice to have an imaging on radioactive iodine too, but as Eyal said initially, we don't want to go there unless we really have to.
Yeah. And Mara, where did you guys go from here?
So we proceeded with a neck ultrasound, which showed that she had these 2 hyperechoic sort of indeterminate nodes in the upper right level 2. And then also went for a non-contrast chest CT. We actually couldn't get a PET-CT approved because she hadn't received radioactive iodine. And so these are just a few of the sample images from this chest CT, which just showed these small bilateral non-calcified pulmonary nodules, which were indeterminate. And we did eventually get her prior CT scan from 2017 after her GVHD treatment and her aspergillus pneumonia, which did not describe these nodules and did not show them present.
Oh, man.
Yeah, it's still not specific because of her
Right.
history. She has
Right.
such a rich history in medical conditions, but it is suspicious. So later on, PET-CT can help if it's active or not, if it's alive or not. Let's say it like that.
Yeah, because this one's still challenging. With 19, you got some pretty good sized lymph nodes. I'm with Dana. I'd really be interested in those retropharyngeal nodes, particularly since we had lymph nodes high in the neck there, on a CT of the neck, or to make sure we're not missing something there. But it looks like we're headed down the radioactive iodine pathway, despite everything that we were saying before. So where did we go, Mara?
So 6 months postpartum, we rechecked her thyroglobulin, which had declined slightly, but was still quite elevated. And the plan that we had was to consider radioactive iodine therapy when she stops nursing, because she's currently still nursing. So some of the questions, and she's currently still nursing as we're having this conversation. So our discussion was sort of, where is our persistent disease? What is the next approach to treatment here? And then the real question is that she's now saying, well, what if I continue to delay radioactive iodine and try to get pregnant again?
Dr. Robenshtok?
I think at this stage that after all the 2 surgeries she has an elevated thyroglobulin and these nodules in the lungs, it can progress with time to maybe life-threatening disease even. It's uncommon, but it isn't like the regular thyroid cancer that we know in the neck. It was fast growing in the neck. I would be worried enough in this case to suggest radioiodine before. Now, if it was a BRAF mutation and I wouldn't think it would work, maybe the consideration was different. With Roth 1, I really don't know. So I think she really needs to have a chance with radioiodine.
Dana, what are you thinking here?
Can I ask a question? I was wondering, well, would you do anything special? What kind of dose would you modulate the dose of radioactive iodine? Would you, what kind of modalities would you use considering her history? Would you give her a lower
I
dose?
would offer fertility preservation before we give radioiodine. And we did a study on elderly patients when for years people would give a smaller dose of radioiodine to prevent marrow suppression, and we showed that it was safe. There was a very mild suppression and then it recovered. So I don't think it's going to be problematic in terms of bone marrow. And in terms of fertility, we can have fertility preservation and then give radioiodine.
So I think we see these very frequently. A lot of times what I'll do in this setting is just a tracer dose radioactive iodine scan. Because if they see lots of uptake in lymph nodes and the lungs, they will often choose to use radioactive iodine up front. If you don't see any radioactive iodine uptake on the diagnostic scan in the setting of structural disease, it doesn't mean radioactive iodine wouldn't be a little bit effective, but it tells you it's not going to be all that effective. And then often a PET scan as soon as I get the negative diagnostic scan and help them make that decision, because the pieces that worry me a little bit are the lymph nodes were growing a little bit fast. We've got these places in the lungs that weren't there after her therapy before. You got a TG that could be either one. So many times in this situation, before we make the decision of treatment with radioactive iodine, I'll think about at least a tracer dose. And I agree, molecular testing and this could help you as well. You know, if it was RAS driven, you'd be more likely to give radioactive iodine, BRAF not. So how are you sort of finishing this one up for me, Maura? How will this one end up right now?
Well, so we're still waiting, and we're planning to do interval surveillance in another 6 months with ultrasound and next CT potentially at that point, and discuss about radioactive iodine. Because I've told her that I think we need to really consider doing the radioactive iodine treatment sooner rather than later. But given her current age and her desire for an additional pregnancy, we have to think about that impact on terms of the timing as well. And, she's previously had 2 rounds of ovarian stimulation without a response and without any good egg retrieval. So we have to keep her goals in mind as well. But I'm quite concerned actually with her persistently elevated thyroglobulin.
Yeah. So one of the questions that came up is sort of a sequence thing here with everybody worrying about lymph nodes in the neck. Should she need another surgery before we gave the dose radioactive iodine? I think all of that would sort of go into the discussion. Many times we do, but if it's a second or third surgery and they're getting radioactive iodine anyway, I've been known to sort of break that rule and just give radioactive iodine. But as a general rule, yes, thyroid cancer is a surgical disease. We want that cleaned out as much as we can, but sometimes these retropharyngeal lymph nodes are a little challenging to get to, and there's some other bad stuff that lives up there. So just balance that in. Okay, Mara. So great issues. We're sort of working through a challenging case that's been through a lot, and she's still working with you, which is great. And just, you got to be patient with them and sort it out. All right, let's look at number 2, as if there's not something else odd from the Northwest. What do we got here?
We have a unique population. So this is a 36-year-old gentleman who was found to have a very large neck mass on physical exam with a new primary care provider. He is a morbidly obese gentleman with type 2 diabetes that's been poorly controlled. He has sleep apnea on CPAP and hypertension. He works for the railroad industry as a freight train conductor. And following initial neck ultrasound and FNA, he underwent a total thyroidectomy for a 4.2 centimeter left multifocal papillary thyroid cancer with no extrathyroidal extension, no lymphovascular invasion, negative margins, and 2 out of 4 central nodes were positive. He then received radioactive iodine, 96 millicuries following thyrogen stimulation. His stimulated thyroglobulin was 4.9. And here's his pre-therapy scan.
So
and
just
here's his post-therapy.
Just uptake in thyroid bed, maybe pyramidal lobe is what we're seeing. No distant
Yep.
Okay.
Yep. No evidence of distant metastases.
So he's going to do great. Next slide.
So he had evidence of biochemical persistent disease. And so his neck ultrasound at 6 months actually identified several nodules within the thyroidectomy bed, including a palpable left nodule right in the surgical scar, very superficial.
Jill,
So
Jill, what are you thinking here?
Yeah, absolutely. So there's a suspicious looking lymph node plastered right anterior to the trachea, maybe a prelaryngeal node. Just one image, but it does look like there's a focus of hyperechoic focus. So this would be suspicious for a metastatic central compartment lymph node.
So Jill, how do I sort out? It seems like every ultrasound after surgery has some thyroid bed nodularity, or sometimes they call it a lymph node. They do vascularity. How do I know when I need to worry about that, or what's just normal there, Jill?
Yeah, exactly. So you're going to see a number of normal structures in the thyroidectomy bed. You may see parathyroid glands, which are sometimes a little larger than normal, sort of recovering from the surgery. You occasionally can see normal central compartment lymph nodes and so forth. But the telltale features of metastatic papillary thyroid carcinoma would be cystic change, echogenic foci, as in the last patient, hyperechoic foci within the node. And we like color Doppler, particularly looking for abnormal peripheral vascularity within the node as compared with central branching. In the central compartment, most normal things have a short axis of less than 6 millimeters, quite different than the lateral compartment. Thinking about the last patient, young people will have nodes 2-3 centimeters all the time. The size is not important. The morphology of the node is most important.
Yeah, and tell me a little bit more. In these thyroid bed nodules, they'll be described as more vascular than last time, less vascular. They don't tell me central or lateral. They just use that one term. Can I do anything with that?
Vascularity is incredibly subjective, both by, the interpreter, but also you change parameters in ultrasound all the time. And again, it's the pattern. Peripheral vascularity, particularly if it maps with hyperechoic foci in a node, is very important. Just saying something is more or less vascular, I don't believe that's meaningful in any way.
It wasn't to me. It didn't help me. I would see it come and go. So maybe we need a little more clarity on where that is. Okay, Mara, what do we got?
We have a few more images from this ultrasound that I'll just show briefly. And then at this point, he actually had an FNA of this nodule that was right along the scar, and that was consistent with papillary thyroid cancer. So he was then sent at this point to our institution.
So go back to that ultrasound for me again.
Yeah.
And show all three there. Let Jill walk through this, because we're up near the skin somewhere here. Is that where we are?
Yeah, Mike, that's actually a really important point. These are sometimes called central compartment, but they're not. They're within the subcutaneous tissues. And I think it's really important to make that distinction. Our surgeons are excellent, but in two occasions, very superficial metastases were not really clearly called out and therefore not resected. My guess is when the retractors go in, you sort of pull the skin to the side and it can sort of be not hidden if you're not, when you're just attacking the central compartment of the neck. So we will see sometimes subcutaneous metastasis, intramuscular metastasis. They're technically not below the fascia and not within the central compartment of the neck.
So this, may I ask if this is a cystic metastasis?
It looks solid to me. It looks hypoechoic and solid. Yeah.
And it's very firm on exam. It's very very hard to and very easily movable around in the skin.
Dana, I mean, if this wasn't this tumor board, scars get little lumpy bumpies. They change. You know, do you worry about this? Do you feel this? What are you thinking when she comes back in? You don't need an ultrasound. You got your fingers.
Well, something that's nodular like that is not very frequent. I mean, you can get thick scars, but you can feel that it's just in the dermis and epidermis. And this is going to be underneath, kind of in the hypodermal region, and that's not normal. And then the ultrasound is going to find more of them. My finger's maybe going to find one, and then ultrasound is going to see where are the other ones. And a little light bulb kind of goes up in my head when I see this sort of thing that's in the subcutaneous tissue. They might have been missed lymph nodes. The one right in front of the larynx, yes, because if you don't take down that hole with the pyramidal lobe, we have to take down that whole prelaryngeal space when we're doing surgery for thyroid cancer, and take down whatever's in front of the thyroid cartilage and cricothyroid. So that might have been missed. But these other ones that are in the subcutaneous tissue, I don't like. I'm going to say this is strange, this is not frequent, this is not normal.
Hey, Bruce, help me out here a little bit. So it's a 36-year-old guy with a papillary thyroid cancer that now we're starting to think he's got subcutaneous mets from thyroid cancer. I mean, is he going to eventually see you? Do these eventually come on your radar screen, or does Dana take care of these? Help me.
Hey, you know, it could be down the line. I would be concerned just based on the short interval and just seeing that this doesn't seem, you know, very usual, and it is a metastatic. So I think we're seeing that this is going to be a high risk patient, you know, so I wouldn't be surprised.
It sounds like that. Margie, to have they're reading this as a 4-centimeter papillary with skin mets. Obviously, you're gonna want to get the slides and look at them. What would you be thinking? Would there be something?
Sure. So again, it's very unusual. The reason I asked, is it cystic, because I'm, you know, not knowledgeable about reading ultrasounds, is that when you have a cystic met, the cysts themselves can sort of dissect around, you know, but that's not the case here. I mean, anecdotally, I've seen this more often with like a Hertel cell, you know, a carcinoma than with a PTC. So for you know, for a tumor without grade progression, and from the previous report, this would be unpredictable. I mean, I wouldn't have been able to predict this outcome from just reading the prior report.
Dana, is this another tumor? I mean, people with thyroid cancer are allowed to have other tumors and stuff in the neck. Anything else we should be thinking about here?
Oh, in the subcutaneous tissue like that?
Yeah.
You can have dermal cysts, you can have benign lesions like that. So I was interesting to get the FNA, but I'm not sure I would think of lymphoma or anything else like that in this case. No, would be maybe benign, you know, something benign.
Jill as well. You see lumpy bumpies all over the neck. Should I be thinking about anything else here, Jill?
Well, no, not, you know, it's a diagnosis of exclusion. It's papillary cancer until proven otherwise.
Gotcha. All right. Mara?
Yeah, so by the time he presented to our institution, his thyroglobulin had actually increased from 1.9 up to 4.9. He had this very hard palpable nodule in the scar that was positive for papillary thyroid cancer. And he underwent resection of the pretracheal Delphian nodal tissue overlying that cricothyroid membrane, the subcutaneous tissue, including the superficial to the platysma, and then deep to this embedded, there was another nodule within the sternocleidomastoid muscle. And I think we have a few of the pathology slides from this resection.
Sure. So what I'm seeing here is just classic PTC. Let's see, can we see the next one?
Yep.
Yeah, okay, if you go back one again, and then, so, I mean, one thing I want to think about is an unrecognized tall cell variant. And this happens to be in the center quite cellular, and at low power, a very hypercellular tumor without colloid, without even the white spaces, would make me suspicious of tall cell. But just on the next image, we're not seeing the tall cell pattern. Still, because it's just two slides here, I would say that maybe this was an unrecognized tall cell, and that would have predicted the outcome.
Yeah.
So this was 4 of the 9 lymph nodes resected in the pretracheal, subcutaneous, and muscular levels were positive, and there was a focus of metastatic thyroid cancer involving the skeletal muscle of the sternocleidomastoid as well.
So Dana, help me understand this operation. I kind of get taking thyroids out, I get cleaning lymph nodes out. This soft tissue and muscle and that sort of, what do you really do when you're in there?
Those are really hard, particularly because it's a re-op and then we're in scar tissue. So it's really hard to know where to go and how much to take out. And if they're big enough to palpate, but sometimes these are like about the size of a grain of rice.
Yeah.
So these are really tough operations. Sometimes, I mean, you see them better on ultrasound than I see them on surgery because they're embedded in this scar tissue. So sometimes we use, we'll put dye. We have a colloidal charcoal, you could get blue dye or something to help the surgeon to make sure that the surgeon is going in the right area in this scar tissue. But these are tough cases. And I think we would have maybe discussed also in this case, maybe going back into the central compartment in the lateral tracheal area, at least on the side of the cancer, maybe to go in, even if ultrasound was negative, we might have going back in once, might have done a reduced central neck dissection, at least on one side, at least discuss it.
Just because of the worry about the natural history.
Because this is, yeah, this is a yucky disease, so.
Gotcha. Okay, keep going, Mara. Let's see what his natural history looks like.
Yeah, so his initial post-op thyroglobulin was mildly, was present at 2.2, and then 6 months later, it's risen slightly to 3.6, but he has new palpable adenopathy, and he also is coming in saying, I feel another nodule in that scar line. So the ultrasound describes 2 enlarged left level 1 lymph nodes, sorry, I'm pointing to the wrong side, that have increased significantly in size. And so at this point, we actually proceeded to a PET CT.
Perfect. And what are we seeing on this? I'm not seeing much of anything. A little bit in the neck up there.
Yeah, so he's just got this left cervical 2A malignant node that's actually pretty large up here, as they're describing it. And then the additional smaller nodes, as well as some small mediastinal nodes. And then there is a focus of uptake within the in the scar line tissue as well. So we continued to follow him by ultrasound, which showed anatomic progression of these sites of disease, and additional non-contrast chest CT showed no metastatic disease in the chest. And so he went to have resection again of this palpable lymph node, as well as the lateral adenopathy.
Again, we're seeing metastatic PTC. There are solid areas in here. So I'm still sticking to my idea that maybe this is an unrecognized tall cell. I can't tell at this power. And again, here it doesn't, it's just PTC. I'd need to look at the slides myself.
Yeah, because what's driving you here, Marge, is just the behavior of this is so atypical for classic, right?
That's right. That's right. So all we're really seeing on paper and on the slides is a classic PTC, no ETE, correct?
Correct.
Right? No ETE, no aggressive lymph node status on, initial, presentation. So, yeah, it does not predict this course. And so again, I have to look at the case myself.
And we did review these slides, looking specifically for tall cell variant, and in all of these cases, we did not see it.
Okay. Okay.
Bruce, Bruce, what are you thinking here, Bruce?
Well, I think it's obviously it's concerning. I think just all these rapid recurrences, I think he's, going to be at high risk for more problems. But I think the main thing, I think, goes back to the surgeon. I think also it would be helpful with further surgery just to, get any molecular knowledge would be helpful, I think.
That's what I was thinking too, to understand what the molecular underpinnings of this is, because this behavior is not looking. Eyal, what are you thinking here as we're walking through this?
So we have these patients who go to one surgery and then another and then another, usually not these that young as this patient. In some cases, the surgeon, after 1, 2, 3 surgeries, tells us, it's the last time. It's really gonna be mutilating to go back there again. And in these cases, if you can get macroscopic clearance of the neck, sometimes we give external beam radiation, which is not a good solution. It's a solution, because if you have recurrence despite of external beam radiation, it's going to be even tougher to treat it next. So these are really difficult decisions. We really don't like treating with external beam radiation in these scenarios, but let's hear what you think.
Yeah, kind of help me think through that, Dana, because I was thinking the same thing. This is going to be, we're back in 3 months, we're back in 6 months. On the other hand, we got lymph nodes high in the neck, they're in the upper mediastinum. I mean, you'd be radiating essentially full neck here. So
Right.
how are you sort of thinking about this?
Yeah, well, I think first of all, for the people who are listening, you've got a scenario. The other scenario would have been missed lymph nodes. If he hadn't had complete neck dissection initially, you can see patients coming back in 2 or 3 or 4 times just because the initial surgery hadn't been complete, and so you're going back into something that's just residual disease or something that's just growing slowly. But this is not at all the case. So I think this has gotten to be a non-surgical, we've gotten to the non-surgical stage. Given his age, I think we would be very reticent to give radiation therapy. If there was something maybe in the thyroid bed that couldn't be addressed surgically, we might propose, some stereotaxic radiation therapy to just very pinpoint something that might be dangerous near the trachea or the esophagus. But I'm not sure that at this point we would be doing radiation therapy. That's just
I
given
think
his
the
age.
discussion we have to have like the genetics of the tumor before raising the question of external beam radiation.
We need molecular analysis on this. I think even once we see that in the muscle, I mean, we're lucky to be able to have molecular analysis really quickly. And I think after that first operation, seeing that in that soft tissue, we would have gotten molecular analysis upfront after that first operation.
Agreed. And at least in our hands, we talk about external beam radiation a lot more than we give it to 30-year-olds. Really, we've done it, right? But you really got to have to earn that treatment, and I think Dana's point is really good to make sure we're not just treating missed stuff from before. I bet 99% of the time that's the way these cases are. They were imaged, and if you did the CT scan, it was there before. All right, Mara, so take me through this one now.
So his initially after this surgery, he did have a decline in his thyroglobulin, but again, he pops up with new adenopathy. It was stable at 1 year. An FNA was done of that right level 1 node that was benign, or at least showed no evidence of malignant cells, but the thyroglobulin wash was not sent. And so then he's got palpable progression on exam. And here's this lymph node. I'm going to sort of breeze through this just in our interest of time. And he undergoes, again, another revision central neck dissection for multiple sites of disease within the left thyroid bed, the strap muscle, paratracheal nodes. And so he just continues to have local recurrences here in the central neck.
Yeah, one of the things that makes thyroid so endlessly fascinating for me is that there are PTCs where I cannot predict the outcome at all. And then it sounds like this would be one of them.
Yeah, and that's such an important point, because we talk so much about risk stratification, and it's low risk. It has to be. Their biological behavior trumps that, right? And occasionally you see lots of funny molecular alterations on the inside that may explain this, and yet didn't really change the histology all that much. So
that's right.
Yeah.
So just to sort of summarize what this gentleman's gone through, he had initial disease was intermediate risk T3A and 1B. He underwent radioactive iodine therapy, but then had radioiodine refractory disease with multiple rapid recurrences in the central neck. So he's now actually had 4 surgeries. He again has a new periincisional nodule on exam, and thankfully has had no significant complications from his surgeries or from his treatment. But I think one of the questions this case really brings up is sort of, when do you intervene on these rapidly recurring cases? You know, how many times can you treat local recurrence? And thankfully, he has no evidence of distant metastases. But we've talked to him each time about, you know, whether or not to consider external beam versus more surgery. And he's obviously been more interested in surgery than the morbidity associated with radiation. But I think this is someone who's going to continue to come back with more recurrences.
And Bruce, these guys always come back and want me to do so. They don't want external beam radiation, and maybe they've got a targeted mutation. Is there any role for something you guys could do to help us here?
I mean, I don't think so. I think obviously it still would be helpful to have the molecular information, but you know, if you're, as far as prevention, you're really not going to treat disease that's not measurable, you know, even based on risk, because as we know, it's basically targeted therapies or just, you know, like even lenvatinib, you're going to give for patients who have disease, and it's not a curative, you know, not curative intent. So you're not doing, by treating early, and you know, is not going to help. I don't think your biggest benefit in general is, you know, prolonging progression-free survival. I would want to wait till I had something to do, and I don't think there's any role for sort of adjuvant targeted therapy, but it'd still be helpful to have the information, I think.
Dana, so this guy's been back 3 or 4 or 5 different times now. How do you make that decision to operate, or when do you finally say I give up its external beam radiation? Think out loud a little bit so we understand.
Yeah, I think it really depends on where these lymph nodes are. If they're near nerve structures, if they're near nerve structures, so we're talking about morbidity. If they're in a neck that's already had complete neck dissection, they're going to be near the carotid artery. They're going to be near some things where surgery is a little bit more at risk. And also the other thing for me is we're at like 4th surgery, a 5th surgery, it's going to be in scar tissue. So I'm less likely to actually have an R0 resection, because I'm just cutting into this scar tissue that's hard as the table. So so I think that those are considerations. Can I get an R0 resection? Where is this location? What kind of morbidity are we gonna get in here? So what's the aim, and what can we do? So I think the lateral neck is usually easier to go back in because the nerves are further away and the structures are further away. The carotid artery is generally really quite robust, but the central neck is much more difficult to go back in several times. So that's kind of what goes through my head.
And Eyal, how do you plan your follow-up imaging on a person like this? I mean, it's CTs, MRIs, PET scans, or from a practical standpoint, what do you really do?
So it's going to depend on the thyroglobulin dynamics. So obviously, quality ultrasound in the hospital, someone you trust. If the thyroglobulin is going up to around 10 or going up quickly, I would do PET scans also. We don't really use CT of the neck and chest because we have PET CT available, but it is an option if it's less available.
Yeah, just there. Yes, I think a challenging case. And unfortunately, these guys that keep recurring like this, I think they do end up with distant mets, although some of them take 5 or 10 years to do it, even though it's running more rapidly in the neck. So I think keeping an eye on the distant places as well is important. So I think you're a challenge. So what are you doing with him right now, Mara? Where are you at with him?
We're still, you know, we're watching with surveillance. He does have a small palpable recurrence in the central neck. He's able to monitor it, frankly, with physical exam, but we're alternating with neck ultrasound and intermittent neck CT with contrast to make sure we're evaluating the retropharyngeal space as well.
Gotcha. And do we have molecular testing on this yet, or are we going
to? We don't at this point. Okay. We're trying to get that, but it's very difficult to get coverage for it out here frequently unless patients have distant metastatic disease. Yeah. So we get a lot of pushback.
Wow.
Yeah, it varies across the world.
But my 2 cents would be to try to get it when you are at that place, get it from the primary resection rather than some of the tiny mets,
Yeah.
some of the tiny recurrences.
Thank you. Interestingly, by the way, his daughter was just diagnosed with thyroid cancer as well and had her surgery just about 2 months ago.
Wow.
Yeah, if you look for it, you find it.
Yeah, well, and I think one of the concerns that this raised was, is she going to have a course similar to him? But obviously, there's no reason to expect his course because it's such an unusual one.
Right. But that always worries families, right? It's the family that had, you know, somebody in my family years ago had anaplastic, or somebody had recurrent disease or multiple doses. It's hard to unhook that. Before we finish up, there's a couple of questions that came in through. Eyal, you mentioned fertility preservation in that early case with IV, and the question is, when do you recommend then that? Do you do fertility preservation for everybody before radioactive iodine? What's your approach to that?
So there are several studies that show that AMH levels that are correlated with fertility are decreased after radioiodine. And there's a very large study from California showing a decrease in fertility rate after the age of 35. So in our system, above the age of 35 or any problems getting pregnant in the past, we would recommend fertility preservation. And in patients with a complex history, like the first one who had bone marrow transplantation, in these cases also, and she also had problems getting pregnant. Sometimes I have 20-year-old patients come in and they read online that they need fertility preservation. There's no data to show that young patients with normal menstrual cycles need preservation. We usually do it over the age of 35.
Yeah. Dana, 2 minutes. Some questions here about high retropharyngeal lymph nodes. Where the heck is the retropharynx? How do you get to them? And what's the issue of operating for the non-surgeons?
The retropharynx, well, for a non-surgeon, it's at the skull base, basically, and you can approach it surgically by going along the carotid. But then there are reports where if it's not too big, you can approach it transorally with or without robotic assistance if you go for surgery. But sometimes, well, when they're very, very big, that's a whole nother problem because you can go in transmandibulally. But so it's at the skull base. And so the surgery is feasible. We've done quite a bit if you want to go in, but it's a risk benefit. Usually with no sequela, there's just some swelling issues post-operatively that are temporary. But then you can also discuss radiation therapy in that area, stereotaxic external beam radiation, or follow-up. So it really has to be decided. You have to decide to go in light of the natural history of the disease. What else is going on in the rest of the body? What's the histology? It's just a whole checklist of items to go into age of the patient.
Perfect. That gets
Does that help?
That's perfect. Exactly what we needed. Dr. Roth, thank you for some incredible cases. I'm glad they were yours and not mine. Those are really challenging. And for the panel for helping out, thanks so much. Enjoy, everybody, and we'll finish there on time. Thanks so much. Have a great week.
Right.
Thank you.
Thank you.
Don't forget
Bye.
the wisdom, the other
Great.
thyroid aspects online. Thanks, team. Bye-bye.
Bye.
Now.
So,